Okay, let's get to some specificity here, and yet try to do this in a way that doesn't feel too overwhelming. Let's first start with COVID. We'll talk a lot about COVID in the pulmonary block in particular, so we'll review it again. But as we think about COVID and the pathophysiology of COVID, I think we've lived through it. Most people have good appreciation for it. As a clinician, we look to see what's updated in COVID, the findings for COVID, the variants that are available, that are sort of running around. You can find that data sometimes at the CDC, at the World Health Organization. But another place that's good to go, particularly as it relates to what the recommendations are for treatments and or vaccines, is the National Institute for Health, the NIH, has a COVID treatment guideline update page that they keep pretty current with what the latest thinking is in the management of COVID. So I think it's important as a clinician to kind of know where the specific things are without worrying too much about the details that may change even over the next year while you're in your clinical year and beyond post graduation for you. When we think of COVID for the vaccinations as they go in pediatrics, they start the vaccine at 6 months of age. 6 months. So COVID vaccines start at 6 months now. Uh, and there really are very few serious considered contraindications for using COVID vaccine in this population. The details for COVID vaccine you'll find in standard compendium. If you wanted to look more closely, you could. These are all published in the CDC, both in the apps and on the CDC's website about the different COVID vaccines that are available and the sequencing of dosing in different ages and how that sort of is manifest. This, with COVID vaccine in particular, evolves and changes, particularly as the variants of COVID have evolved. The vaccines try to keep up with that, similar to how we do it with influenza, where there are a fair amount of variants evolving over time as well. And for adults, and you'll see the difference in the slides for adults here, I've put the little logo of 19 plus as opposed to the teddy bear. COVID plus, everyone is a candidate for COVID-19 vaccine. And again, there are no major contraindications for using COVID vaccine. The adult recommendations are also pretty specifically outlined in the CDC. I would not have you have too much detail in knowing that for the sake of this block, but we'll talk about this a bit more in pulmonary block and we'll get a little more detailed there. Second is dengue fever. Dengue is not common in most of the continental United States, and this really falls into some of I think it's Puerto Rico, maybe the Virgin Islands, maybe other territories in the United States. But dengue fever, generally asymptomatic to mild, but sometimes it can be quite severe. And there are concerns in practice in certain populations where that would be an issue. But in most of the continental United States, dengue is not as common a situation as it is in other areas of the world. But if you are practicing in an area where it is common, there is a vaccine. The vaccine recommendations are listed in the sequence, but again, they're pretty much for people who are in areas where it is endemic. There are some contraindications for using the dengue vaccine in pregnancy and in individuals who are immunocompromised, so you want to be aware of that. But we primarily think of dengue vaccination in the realm of pediatrics. There really is not a specific recommendation in adults for dengue fever in most people, so that's a vaccine that you don't need to spend a lot of time focusing on. Again, contraindications, dengue is not even listed. Dengue is not even on the adult schedule. Although it is some data listed there in children aged 9 to 16. All right, let's go to diphtheria, tetanus, and pertussis. Now we've mixed three pathogens here because the vaccine contains all three, although there's tetanus toxoid that's available, or diphtheria and tetanus that's available as well as separate vaccines. But let's go through these diseases first, and then we'll talk a bit about the vaccines in both pediatrics and adults. Diphtheria identified, 5 centuries BC or before the Common Era, and there are epidemics that have been described in history as soon as the 6th century, and first identified as the bacterium first observed and cultured in the late 1800s, with the toxoid developed in the 1920s. It's an aerobic gram-positive bacilli. Its pathogenesis is related to the toxin it produces. Its clinical features are an incubation period that's 2 to 5 days and involves often mucous membranes. The complications can be attributed to the toxin and include myocarditis and neuritis, and it has a 5 to 10% fatality rate. So here's an example of deaths that can be avoided by a vaccine that's available. The epidemiology, reservoir is human, and there's more data there. And the trends, once the vaccine was available, it's a pretty uncommon scenario to see. In the 20 years prior to 2018, there were 14 cases and 1 death reported in the United States, compared to, look at this, 15,000 deaths a year before 1920 when the vaccine was available. So really a very preventable disease by vaccine. The efficacy is greater than 95% after you've gotten 3 doses. That's excellent. Let's go on to tetanus. Tetanus is caused by an exotoxin produced by Clostridium tetani. It's characterized with rigidity and convulsive spasms. It's been around for a while. The tetanus toxoid was developed in the 1920s and started to be used during World War II pretty widely. It's an anaerobic gram-positive spore-forming bacteria. It enters the body through wounds. Typically, you think of the rusty nail, but really through dirty puncture wounds, typically. The spores germinate in anaerobic conditions, and it leads to unopposed muscle contraction and spasms. Incubation period is 8 days. There are various forms, and the complications can include lots of things, including death. The epidemiology is soil transmission. It's otherwise not particularly communicable. So tetanus does happen, not very often, but truth be told is that we had a case in our ICU of an individual who had not kept up with the vaccinations and developed tetanus and ended up having to be in our ICU on a ventilator and neuromuscular blockers in place to prevent the serious contractions he was having. He ended up doing okay, but it was a major ICU event on a ventilator, not a pleasant situation to be in a disease that is pretty much preventable by administration of a tetanus toxoid. The efficacy with 3 doses is almost considered universal. The third disease here is pertussis, Bordetella pertussis, also known as whooping cough. There are lots of cases that still occur in the US, but not as much as it used to be. This is an aerobic gram-negative bacteria, and there is sort of a lot of things to think about with pertussis, but we really worry about this in newborns and hope to have some degree of herd immunity for those individuals who are around someone who doesn't yet have pertussis immune status to it. Pertussis is primarily a toxin-mediated disease that causes significant pulmonary inflammation. The clinical features have an incubation period of up to 10 days, and then a more severe cough, often with some very serious coughing, and with recovery. And the coughing, it has a classic whoop, hence it's called whooping cough, but it has some complications that can happen too. So the complications include most commonly a secondary bacterial pneumonia, which can be fatal, and it's young infants who are at the highest risk because they can't yet mount an immune response, and their vaccine, because of their immune response with vaccines, is a bit delayed. So what we hope for is a degree of herd immunity around that newborn patient. And there are deaths. So again, another death prevented by a vaccine. One death in a vaccine preventable disease is one too many. The epidemiology, typically human transmission, person to person via droplets. So we are really hoping that those around the newborn will have adequate immunity to pertussis. The trends here are listed with pertussis. And it's pretty effective to highly effective vaccine, enough for herd immunity. And I think in practice, we see periodic outbreaks of pertussis. I know in a region in western Massachusetts, in Holyoke, there was outbreaks maybe 5-6 years ago, maybe it's a little longer than that. But periodically we hear of these vaccine preventable epidemics that happen in different regions. The data for the vaccines in children, they start at 2, 4, and 6 months, but you really don't have a good response in those first until you've really completed the series, and that's after 6 months. So the first 6 months of a newborn is really quite vulnerable to pertussis. There really aren't a lot of contraindications for using diphtheria, tetanus, and pertussis vaccine. And there are the guidelines for the concern for routine vaccination in pediatrics. More specifics about how they're timed and catching up. Don't worry about the details here. And in adults, they are candidates to get every 10 years to get a tetanus and diphtheria. And if you haven't had a recent tetanus diphtheria vaccine, then you want to make sure that you get one with acellular pertussis as well as your first one, and then continue with diphtheria and tetanus vaccines thereafter every 10 years. Finally, not a lot of contraindications in use, although some specific issues perhaps in pregnancy. Again, there are the particular situations in pregnancy. The guidelines are 1 dose with each pregnancy, particularly early part of gestational weeks 27 through 30. Also, it's pretty common to see it used as part of wound management as well, because wounds, particularly puncture wounds, where dirt would be projected to be an issue, is a real concern. All right, hepatitis A. Hepatitis A, particularly oral fecal route of administration. Hep A, we often see varying degrees of epidemics of jaundice attributed to Hep A. That's been reported for millennium. What you'll find is Hep A is an RNA virus. Its pathogenesis, again, oral fecal transmission, replication in the liver, causing primarily liver injury. Clinical manifestations, it has an incubation period of almost a month. And then the symptoms are quite abrupt, with dark urine and jaundice, and seeing varying degrees of illness, partly related to age. It's a human reservoir with oral fecal transmission. The trends where it's epidemic particularly are seen in areas where there's a compromised, for example, sewer system or something, which might be seen in parts of the world, but also more is seen, for example, in times of hurricanes and floods, where those septic systems might be compromised. And so it might be a concern for responders to those settings, first responders in particular, and people living through that. The vaccine is quite effective at 95 to 97% effective. It is a routine vaccine in pediatrics. It is also recommended in adults, but that's the children's studies. In adults, it's recommended as either catch-up or in circumstances where someone is at a risk factor for Hep A. Again, no major contraindications for using Hep A vaccine in adults either. And there are some of the specifics for Hep A. Let's go on to hepatitis B. Hep B is also been identified for millennium, and we found the first recorded cases in the 1800s. And then it wasn't really until the 1960s that we began to find that we had some good data for first identifying the antigen and then developing a vaccine in the 1980s, and replaced then with a recombinant version of the vaccine in 1986. The virus itself, it's a DNA virus. It has multiple serological markers, and it's infectious for at least 7 days on surfaces, which makes it a really problematic pathogen. Most other viruses aren't remaining that alive that long on a fomite or a surface. The pathogenesis is transmission primarily by parenteral or mucosal exposures. It replicates in the liver. Its clinical features, its incubation period is 60 to 90 days. It has a prodromal period phase where there's icteric or jaundice occurring, and then a convalescence phase. And while most people recover from Hep B, there's a subset that don't. The complications can lead in about 1 to 2% of the population to lead to fulminant end-stage liver failure and death. So it is a really concerning disease if it comes about. Chronic hepatitis B infection happens in a subset of patients, and so it's important to do that. It's the hepatitis B vaccine is the first vaccine that we will use in newborns, usually in the first hour of life, they get their dose. But the epidemiology, it's human reservoir with body fluid transmission. It can be communicable in mucous membrane transmission as well as IV or blood transmission. The trends are before the vaccine, there were many more cases than post-vaccine. This is very common for most people in the population to have Hep B vaccination. Healthcare workers also very strict about healthcare workers getting up to snuff on vaccines. One of them is Hep B. The vaccine is pretty effective, not 100% effective in absolutely everybody, but pretty effective and titers for most people with Hep B vaccine. In newborns, again, the first vaccine out of the chute. And for pediatrics, no contraindications that are major ones. And there's the guidelines for Hep B. In adults, it's completing their series if they haven't had it to get through it. And again, not too many major considerations for avoiding use of hepatitis B vaccine. Finally, in adults, there are the specific recommendations for the vaccine. You can also see these in the CDC's website. On to Haemophilus influenza. Haemophilus influenza, or H-flu. This particular pathogen we will talk about again and again as a common pathogen in upper respiratory tract infections, particularly otitis media in children, sinusitis in children and adults, and lower respiratory tract infections, pneumonias, in community-acquired pneumonia, particularly in pneumonia with individuals who are smokers. So Haemophilus influenza type B, a subset of Haemophilus influenza, causes significant bacterial infection in infants and adults. It's been around, a long time, but not discovered until the late 19th century. At that point, this bacteria was believed to cause influenza, hence I get its name, Haemophilus influenza, which is not to be confused with the virus influenza. So you want to be clear that the name sounds similar, but this is a bacteria. But it got the name because there was a time when it thought that this was influenza. It's not. Okay, but it's a pretty common cause of bacterial infections, both pulmonary but also meningitis. So particularly in meningitis, before the vaccines were available, this was a very common etiology or cause of pediatric, infant meningitis. So it was a real concern, more so in the pre-vaccine era. It's an aerobic gram-negative bacteria. It has 6 different serotypes. It's a pretty invasive disease, particularly the type B is. The pathogenesis, it enters and colonizes in the nasopharynx, but can lead to varying degrees of disease. The clinical features are often risks for meningitis, bacteremia, epiglottitis, pneumonia, arthritis, and cellulitis. It's a human reservoir with person-to-person transmission via droplet. And we still see cases of it, but not nearly what we saw in the pre-vaccine era. The vaccine efficacy is greater than 95% when we use it in newborns and infants. And the sequences dose 1, 2, and 3 are 2, 4, and 6 months out, with a booster dose later on in childhood. And no major contraindications for its use. There are the specifics for Haemophilus influenza vaccine in children. In adults, there is a role for people who have not had it as part of childhood, but there is a less of a widespread use for everybody. It depends on what their history has been. And again, not major contraindications for use. But it's pretty much led to people who really are asplenic. That's usually the patients who are primarily candidates for this strain, vaccine for this strain of influenza type B. The other types of influenza, Haemophilus influenza, that are seen in adult infections are not always the type B that is more involved in the meningitis risk and the pulmonary risks in newborns. Next is human papillomavirus, or HPV. That's a small DNA virus. It is associated with causing significant infection and risk for warts and cancers. So HPVs infections are usually asymptomatic, but they can be responsible for a range of infectious processes, including anogenital warts, recurrent respiratory issues of inflammation, and significantly cervical cancer and anal, vaginal, vulvar, penile, and oropharyngeal cancers as well. So the vaccine has a particular, what's remarkable about this vaccine is this vaccine actually helps prevent cancer. So the epidemiology, primarily direct contact, usually sexual, but not always, contact for human papillomavirus. The trends are that it is one of the most common sexually transmitted infections in the United States. It's quite common among adolescents and adults, and many people are asymptomatic, and yet it could still increase the risk for cancers, including cervical and regional cancers, wherever the site of contact was. The vaccine is highly effective and is recommended across the board in both pediatrics and in some adults. We'll look at the tables. In pediatrics, it has a role starting in the early teens. And it is a vaccine, human papillomavirus, we avoid in pregnancy. And we have specific roles for when we give it in immunocompromised individuals in pediatrics. So there are the specifics for HPV. Minimum age is 9 years of age. And then they talk about immunocompromised conditions, including HIV, where a 3-dose series might be considered. And then in adults, it's recommended for people up to the age of 46, I think it is. But it's shared decision-making beyond the age of 26. What is interesting when I speak with colleagues, there's nothing really magic about the age of 46. If people are sexually active, then it makes sense to consider this vaccine, except that people over the age of 46 likely have already gotten exposure to HPV. If they haven't got it by 46, they probably never would. So there's some data that suggests that perhaps people over the age of 46 might be a candidate, but currently that's not in the guidelines. And lastly, the recommendations for adults with HPV, we avoid it in pregnancy. Otherwise, it's a really case-by-case situation for these other comorbid conditions. And there is the more adult specificity for HPV. Let's go on to influenza vaccine. Influenza, very common. This is something we see in North America. We give this as a annual vaccine. The vaccine formulation changes every year based on what the prediction is for the circulating variants of influenza. It's a viral illness that had its first documented pandemic in history in the 1500s. But if you're familiar with history, and I think most folks who've gone through COVID heard about somewhere the 21 million deaths worldwide in the influenza pandemic of 1918 and 1919 during World War I. They first isolated the viruses in the 1930s and started with vaccines by the late 30s and early 40s. It's an RNA virus. There are different subsets of the influenza virus, and then again, different strains of those viruses. What you see here, and this is the same thing we see with COVID, is we see antigenic drift, small mutations over time that result in novel strains. And so what you will find is that every year, you can get influenza multiple times in your life, even if you have good immunity after one particular bout of influenza or a vaccine for influenza. The strain may have changed, and so you don't really respond to that. And then some years, the matchup for the vaccine, the quadrivalent vaccine is pretty much the standard one we use now, which are 4 valences out of how many more they could be. You generally are reasonable at getting some degree of protection, but some years it's a hit and some years it's a miss. So influenza pathogenesis, not only does it cause respiratory transmission and involve in the pathology and clinical symptoms of respiratory problems, but also fatigue and muscle aches and other problems as well. So the clinical features, incubation period's about 2 days. About 8% of the United States population get it each year. It can have a respiratory presentation and a systemic presentation, sometimes a GI presentation as well. Usually it's a rapid recovery, but who's at risk for complications? Generally older people who have other morbidities as well, and the risk really is secondary bacterial pneumonia, maybe an exacerbation of their underlying respiratory condition, otitis media, or bronchitis. Other kind of complications can occur as well. So influenza can be fatal depending on the strain, the virulence of that strain, the immune status of the individual who's infected, and what other kind of secondary bacterial risks they may present with. The epidemiology, the reservoir affects humans and some animals. You kind of know that there's kind of the animals we often think of are avian, as in bird-related infections as well, but there can be other sources as well. But largely, it's large droplet transmission, and in North America, the peak season is between October and April or May. The trends are that it's pretty common to see, and we look at about 35 to 40,000 influenza-associated deaths a year. Many of those are preventable deaths by vaccination, but we have to be clear that this is one vaccine, because of the genetic drift, that it's not quite as universally effective. So we find that the efficacy ranges on average between 40 and 60%, but that really depends on the strain that is chosen, and that has to get chosen for manufacturing reasons, estimated or predicted what's going to be the strain in North America in October through May of the following year, when it has to be decided by probably the latest March of the year, where it has to be available as a vaccine in September, October, for it to be manufactured. And that guesstimate might be on target, or it may not be. But why is this vaccine so touted with this kind of efficacy data is that, look at the numbers, 37,000 deaths a year from a potentially preventable disease. Even if it was only 50, 60% effective, half of those deaths could be prevented. That's still a very large number. So, influenza vaccine is one of those that can be, it's always worth getting, and the benefit of it might be better some years than others. The tables indicate for pediatrics, you could use either the inactivated vaccine that's given by injection, or the live attenuated vaccine, which is nasal inhaled. Here's the problem with the live attenuated vaccine, nasal inhaled. It's only given for older children and adults below the age of usually 45 or so. And it's not really the preferred vaccine to use, but if they're needle phobic, this is a nasal administration. The problem with the live attenuated vaccine is that people can get more of an influenza-like reaction, and they might also shed that live attenuated vaccine given intranasally to someone who is immunocompromised. So if the person lives with someone who's immunocompromised, or they work in a setting that there are people like healthcare workers who might come in contact with someone who's immunocompromised, we really don't recommend it. Universally, I think most clinicians have recommended the inactivated influenza vaccine. And while in this current 2023-2024 winter season, the FDA has approved in a live inactivated nasal vaccine for the market. Over the past 3 or 4 years, some years there have been one available, and some years the FDA did not approve it at all. So that live inactivated nasal vaccine is not always available every year. In adults, we avoid the live attenuated vaccine in anyone who's immunocompromised or could be pregnant. And really, for any but other comorbid states, we really don't recommend it either. So the universal one we recommend is the inactivated vaccine. It's not really that uncomfortable an injection compared to maybe even some others. It does cause some arm soreness pretty frequently, but that's about it for most people for significant side effects of influenza vaccine. Not universally, but most people. So there's some of the detail for influenza vaccine. In pediatrics and for adults, again, universally, the inactivated agent is sort of across the board, where over the age of 45 or so, we don't recommend the live attenuated vaccine. And again, the live attenuated vaccine is not recommended for folks who are immunocompromised or pregnant. There are the adult categories. Okay, we have a few more of these to get through, and then we're almost done. Measles, mumps, and rubella. Measles is a viral infection that's been around, first described in the 7th century. The first measles vaccine came in 1963, and the combination measles, mumps, rubella in 1971, and a recombinant version was available in 2005. It's a very common infection in the pre-vaccine era. It was almost considered universal because it is very highly contagious. It is still common and often fatal in developing countries and in pockets of the United States and North America where vaccine adherence has been less than optimal. The virus itself is an RNA virus. It has one antigenic type. Its pathogenesis, it's a primary site of infection, are macrophages or dendritic cells. It produces a viremia. That's a pretty robust one within the first 2 or 3 days after replication, and a second one after 5 to 7 days after exposure. Clinical features, it has an incubation period of 10, 11 to 12 days, and then you see this rash, the prodrome, with often a fever, a cough, and then a rash that persists for 5 to 6 days that begins at the hairline and starts to proceed downward from there to the hands and feet, and severe areas peel off in scales. Complications of measles, and they can be serious, are diarrhea, otitis media, pneumonias, encephalitis, and panencephalitis, and fatalities. And it is more common in younger children and children below the age of 5 years, but also can be common in adults. The epidemiology, its transmission is person to person and airborne in enclosed areas for up to 2 hours. It can linger, so this is highly communicable. Basically, the rule of thumb is if you had an airplane, a 3-hour flight on an airplane where one person had measles, if nobody were vaccinated on that plane, everybody would have measles. Maybe not everybody, but a good portion of the plane would. Its secular trends, before the vaccine, it was very widespread with about 500 deaths annually. But with vaccine availability, it became sort of much more in control. But we have outbreaks reported, and that is directly related to areas that are not adequately vaccinated. Immunity is almost universal if you were born before 1957, because it was pretty common. And I will say, I remember when that was the year of my birth, so I'm divulging my age to you. But in our childhood, it was very common that, Billy up the street has the measles. Let's go play with him for a while, so that everybody got their immunity over with early in life before the age of vaccines were available. The efficacy of the measles vaccine, highly effective in about 95% of people who are vaccinated. Mumps. Second one is mumps. Again, another acute viral illness that produces orchitis. It's been reported for years from the age of Hippocrates, 5,000 of 5th century BC, 500 BC. And it was a very common cause of aseptic meningitis and hearing loss in children before the vaccine was available. Vaccine led to over 99% reduction in the cases of mumps. It's an RNA virus. It's respiratory transmission. And it presents with an incubation period of 16 to 18 days. It has a prodrome of myalgias, malaise, headache, and it presents with a parotitis, which is sometimes pretty dramatic. Often with varying degrees of respiratory symptoms. Complications include many listed here. Some of the major ones can be hearing loss, meningitis, and ultimately leading to patients becoming infertile. So that can be an issue. Its reservoir is human, and respiratory droplet secretions or saliva. It's communicable from 2 days before through 5 days after the onset. And it is reported a number of cases after the vaccines become available. It got much better, and it has gone quite a bit down, but it is still occasionally reported as well. Immunity before 1957 for mumps, like with measles, was almost universal because everybody was go play with Billy. The vaccine is highly effective at about 94%. And finally, rubella, also known as German measles. The real concern here is congenital rubella syndrome. In a woman who's pregnant or could become pregnant, rubella can be a very highly risky pathogen virus that leads to miscarriages and or at least fetal malformations and teratogenicity. So it's a rubevirus, an RNA virus. It is a respiratory transmission, and we're very concerned about transplacental infection of the fetus during an episode of viremia. It can lead to hearing impairment, ocular, cardiovascular abnormalities in the fetus. Incubation period is about 14 days. Complications are encephalitis. Hemorrhagic manifestations happen in about 1 in 3,000 cases, and sort of other complications listed here as well. And congenital cases lead to miscarriage, stillbirths, birth defects. Epidemiology, again, human, person to person via droplets. Since the vaccine's introduction, cases have declined dramatically. And then since between 2012 and when they published this in 2021, when they published this data, there had been no cases except for cases coming in from other countries. Rubella immunity, again, was almost universal before 1957, but thereafter was really much better controlled with vaccination, and the efficacy is about 95%. Measles, mumps, rubella in pediatrics, it is, we kind of look at the range of when they're hitting, and we hit these early on in the cycles. And the contraindications, because it's a live vaccine, avoided in immunocompromised individuals. The vaccine series happen at age 12 to 15 months, and again at age 4 to 6 years of age. And in adults, we look at dosing for folks under the age of 65, particularly as it relates to either their titers or their prior vaccination status. And again, measles, mumps, rubella being a live attenuated vaccine is avoided in pregnancy in immunocompromised individuals across the board. There is the data for the adults. Let's go on to meningococcal disease. This is a leading cause of bacterial meningitis, particularly in the pre-vaccine era. There are 5 particular meningococcal vaccines in the United States, and it gets kind of confusing about how those are navigated. Most of that's going to be given to high-risk adolescents and young adults, and there's a whole way to strategize around that when you look at the app to help you figure that out. Neisseria meningitidis is an aerobic gram-negative bacterium that has specific antigenic components to it, and the serogroups vary, and the vaccines then are specific for some of the different serogroups as well. Meningococcal disease pathogenesis, it attaches to and multiplies in the nasopharynx and the oropharynx, and it can become a bacteremia in a small subset of patients, but that can then lead to the risk for both systemic disease and meningitis. The clinical features has an incubation period of 3 to 4 days. Meningitis is the most serious and most common of the serious invasive disease you'll see with a sudden onset. Meningococcal septicemia also has an abrupt set of fever. There can be a bacterial pneumonia, and it can sometimes be sort of non-invasive types of infections as well. There are multiple risk factors, and you can see them listed here, including housing and smoking and the nature of exposure and the nature of someone's, whether they have a spleen, whether they have HIV, something else. So risk factors that predispose to the, after exposure to a more invasive disease. This is one area when we talk in neurology about Neisseria meningitidis and meningitis, we'll talk about the antimicrobial chemoprophylaxis for patients who are truly exposed, where the antibiotic we typically use is rifampin. It's usually a 4-dose regimen. We'll talk more about that situation later in the year in neurology. Meningococcal disease epidemiology, human reservoir with respiratory droplet or direct contact with respiratory secretions. Its trends are not all that many cases, but they're serious, and there are different subgroups that cause different pathology. The vaccine is considered pretty effective, but again, there's a quadrivalent vaccine, there's a serogroup B vaccine, and kind of lining up the vaccine with the risk category group, the age, is this a younger adolescent? Is this someone who's living in congregate housing, like in college students, for example? The data sort of list which of the vaccines in pediatrics are dosed in which windows of time. And there are, depending on the agent, varying degrees of concern with some or not, but usually it's pregnancy with one of the vaccines. There's some concern about pregnancy risk because it wasn't really trialed as well. And then the specific data for the meningococcal vaccination groups, A, C, W, and Y, and then meningococcal serogroup B vaccination and when those fit as well. For adults, again, the vaccines are particular through the age group. The Venenjel B is the one that's recommended in the window of time for college-age students classically. And then the contraindications, relative contraindication or concern, perhaps in pregnancy. And again, in adults, that's the more specificity for the vaccine status for meningococcal vaccination. In adults, this is the ACWY, and then there's the meningococcal B version. Okay, the next concern here is Mpox. You may have heard the earlier terminology that got changed. This is used to be called monkeypox, and the terminology was less divisive to call it instead Mpox. And the data for this agent, it's a pox-like version that's similar in a sense to smallpox, with varying etiologies or concerns, not quite as severe as smallpox. The manifestation periods, incubation period is 3 to 17 days. The duration is 2 to 4 weeks. You can often have a fever, malaise, headache, and weakness. You can have a lymphadenopathy seen. And then you end up often with these lesions. They typically appear shortly after the prodrome. There's a macular, then a papular, vesicular lesion a pustular lesion, then ultimately a scabbing over. The classic presentation is seen here. And you'll see people who are at risk are particularly folks who have immunocompromised status for whatever reason, immunosuppression. And then in certain areas, particularly if their exposure was particularly high, might be higher on certain surfaces than other, particularly, and this is often a case where it's sexually transmitted. So you'd be worried about the genital area, the genital anal area being a concern of particular risk. There is an ocular complication associated with it. And severe lesions can occur in lots of places, causing lots of distress for people. The vaccination is really listed for people over the age of 18 and over, so it does briefly come into the pediatric table because that goes for ages 18 and younger, and this is for 18 and over. And it is limited in who is a candidate for it. The vaccine lists are there, again, ages 18 and over for folks who are at risk for infection. And in adults, again, it is a high for people at risk, not universal. And then there are sort of concerns, a list that are specific, that they refer you to the specific data for it. With Mpox, it's a 2-dose series, and there's concerns that you can't get other vaccines within a certain window of time for getting it. So there's a bit of idiosyncrasies about how you can schedule that if you're also trying to have individuals at the same time scheduled for other vaccines. Let's go on to pneumococcal vaccine. Pneumococcal disease, strep pneumo, has been isolated since the late 1800s by Pasteur, and the first vaccine available in 1977. The Streptococcus pneumonia is an anaerobic gram-positive, it's a facultative anaerobic gram-positive organism with multiple serotypes, and most serotypes cause serious disease, but only a few of them cause most commonly the pulmonary infections. The serotype prevalence can differ by the age, geographic region. What gets a little confusing is based on those serotypes, which there have been multiple different vaccines with different serotypes available over the years. They've pretty much streamlined that over the last couple of years. But the pneumococcal infection is commonly seen in the respiratory tract. You'll see that its clinical features most often include pneumonia or a bacteremia and sometimes meningitis. In adults, pneumonia is what we commonly see. You can see a bacteremia and then sometimes a meningitis as well. And the bacteremia and the meningitis can have pretty significant fatality risk of 12 to 14%. So that can be quite concerning or alarming. In children, we worry about pneumonia, bacteremia, and also, again, meningitis. And also, pneumococcal is a common cause of otitis media. So getting vaccinated appropriately in children may also lower the risk for otitis media. The epidemiology primarily is person-to-person contact through respiratory droplets. The disease trends, we still have cases and deaths from invasive pneumococcal disease. More than half of those have occurred in adults. And what we have is multiple vaccines that are available. What's a little confusing is this data was with the no longer commonly used pneumococcal vaccines. So I wouldn't spend too much time on the specifics of that, but just sort of recognize that the vaccines have evolved to be pretty effective over time, but we still see this disease prevalent. And the efficacy, again, 60 to 70% for the most part with a combination of these vaccines. The newer PCV20 was not available when this data was published by the CDC in 2021. The PCV20 is the standard pneumococcal vaccine now in adults, and particularly over the age of 65. And the data for that is at least as good as the older data was. The childhood immunization for the particular forms, and they vary in which variants are looking for pneumococcal vaccine, started at 2, 4, and 6 months, with a booster later on at 12 to 18 months. And no major contraindications in children. In adults, that's again in children, is specifics for the pneumococcal vaccine. This is data for age, the 4-dose series at 2, 4, 6, and 12 to 15 months. And then there's special situations in the age of 2 to 5 and age 6 and beyond. There are, in adults, recommendations over the age of 65, and in subgroups who have specific high risk below the age of 65, particularly folks who have diabetes or pulmonary infection risk or other risk factors or otherwise immunocompromised. And there aren't too many real contraindications for using the pneumococcal vaccine. So again, routine vaccination for pneumococcal vaccine in adults over the age of 65, but you'll also find there are data for other groups as well. There are specific sequencing in the age before the pneumococcal 20 vaccine was available. And so you'll see almost this confusing sequencing of the prior vaccines that were available. I refer you to go to the CDC's website when you're in practice to kind of see where is somebody in that pneumococcal vaccine status, which formulation did they get, and what are the candidates for something newer. For special situations, we do look at pneumococcal vaccine when patients have a specific risk factors, and we usually think of things like otherwise immunocompromised status, history of comorbidity with diabetes or with pneumonia, risk that's higher because of pulmonary infection, something like that. Polio. Polio was a very commonly concerning pathogen prior to 1960. Poliomyelitis first described in the late 1700s. It caused significant cases of paralysis in the United States in the early 1950s. And the last case of wild poliovirus acquired in the United States was reported in 1979, but it's still an issue in other parts of the world. The poliovirus is an RNA virus with different serotypes. The pathogenesis is oral pharyngeal. Poliomyelitis has an incubation period of almost a week, and then an onset of paralysis that can sometimes be permanent. It can be variant in which paralysis where it occurs. The epidemiology, again, is oral fecal or oral transmission. It peaks in the summer climates. It's highly infectious. And it was a major concern through the 1950s until we had the availability of inactivated and oral active polio vaccines. The eradication occurred from the 1950s to the present. There's still some polio around the world, but the Western Hemisphere is generally considered free of polio. We always, though, are concerned if our vaccine programs become less robust, could this be a concern again? The vaccine is quite effective and at least 99% immunity after 3 doses. And there is the sequence in pediatrics, a dose at 2, 4, and the third dose somewhere between 6 months and 18 months of age. And then there, other than pregnancy, there's no real concerns with its use. There's the schedule for the sequencing of dosing the first 3 and then the 4th dose at 4 to 6 years. In adults, it's really not on the schedule, but you might find somebody who has never gotten polio vaccination and that might be a case-by-case evaluation, perhaps with infectious disease service. Again, inactivated polio is not on the adult schedule. There are recommendations for how to complete, though, polio vaccines in individuals who have never been vaccinated. Nearing the end here in alphabetical order, respiratory syncytial virus, or RSV. RSV has always known it, or recognized it to be a considerably concerning disease for infants and young children, particularly neonates, and particularly immature neonates who were born prematurely in the and are what we call neonatal intensive care unit graduates. Those individuals often had birth before they had adequate surfactant, and so they were more prone to RSV infection complications. So the approaches in pediatrics are that we can both offer passive immunity for very high-risk patients by giving them antibody therapy directed against RSV during the peak season. And there's also now a pediatric RSV vaccine available as well. There's also an RSV vaccine available for adults, and it is in patients over the age of 60 are candidates, particularly might be a bigger risk for patients who have pre-existing pulmonary or metabolic concerns if they have cardiovascular disease or diabetes as well, although pulmonary disease is probably the biggest risk here. The schedule in RSV pediatrics, there are 2 RSV vaccines, both the adult version and the newborn version. So you want to be clear of which vaccine you're looking at for which population. And then the guidelines for contraindications pretty well tolerated overall. The RSV and in a newborn is listed here, and then the RSV vaccination beyond that, there's different formulations depending on where you're hitting them in the cycle. Finally, in adults for RSV, the criteria are over the age of 60. There might be limited indications for patients otherwise, and the big indication there is pregnancy. During a week of pregnancy, RSV, you actually want to offer some degree of antibody protection and passive immunity to a newborn, and so it is recommended as a vaccine during pregnancy. So the criteria in pregnancy is particularly weak. It's given during pregnancy. And so RSV routinely at 32 weeks through 36 weeks. And then in special populations over the age of 60 as a shared decision-making process. Rotavirus is primarily a pediatric concern. I mean, it's true in adults too, but more pronounced and potentially more sequelae and concerns in pediatrics. First identified as diarrhea in 1973, pretty late. They've had a couple of different vaccines available over the years. The earlier version of the vaccine had some complications with it and was pulled from the market. But rotavirus is an RNA virus, the pathogenesis is its entry through the mouth, and the clinical features with a up to 48-hour incubation period often is severe gastrointestinal symptoms that resolve in 3 to 7 days with severe dehydration, diarrhea, fever, and vomiting. Complications with severe dehydration seen, electrolyte disturbance, metabolic acidosis. So you're really concerned about that. And as you learn in pediatrics, so you will learn in pediatrics, that the changes in fluid and electrolytes, you really don't have as much margin for error in a newborn or a young infant compared to an older infant or an older child or an adult. So the epidemiology is human GI tract and stool, oral, fecal, and person-to-person transmission and fomites. And so rotavirus infection, for example, is seen on, among other things, cruise ships. So you want to kind of be aware of this is an issue for everyone, but the complications are potentially more severe in young infants. Rotavirus, generally pre-vaccine, were millions of cases each year, and with now having the vaccine available, we generally see significant reductions in those cases. It's pretty effective at about 75 or 80 to 85% or so, and preventing severe gastroenteritis much better than even that. So it has a series in pediatrics at 2, 4, and 6 months. And it has some concerns in individuals who are immunocompromised. It is a pediatric vaccine scheduled, again, dosed at those 2 or 3 dose series, depending on which product is chosen. It is not on the adult schedule. It's only indicated for pediatrics. Varicella. Varicella is a concern for everyone, really. Chickenpox is what it's often called as well. Varicella, acute infectious disease, distinguished from smallpox by the end of the 19th century. It's a live attenuated vaccine that we use since the 1970s. It's a DNA virus. It enters through the respiratory tract and the conjunctiva. It has an incubation period of about 2 weeks or so. And we often see a rash as the first sign of disease. The complications are secondarily bacterial infections, pneumonias. They can be quite severe in immunocompromised patients. There's concern for central nervous system involvement, including encephalitis, and Reye syndrome can happen particularly in pediatrics. So we have a congenital RSV infection concern from mother to newborn in the first 20 weeks of gestation. The epidemiology, again, is human, person to person, or direct contact with vesicular fluid can be problematic. Virtually all persons before the advent of the vaccine acquired it in adulthood before the vaccine was available. And so all of us have varicella who are over the age of 50, have varicella sort of dwelling in our nerve endings. So that's a concern for us who are older. The vaccine, though, when it became available, was highly effective, almost 92% after the second dose. And in pediatrics, it is sequenced at 12 months and again at is that 4 years, 4 to 6 years? Yes. So it is a live vaccine, though. So because varicella is a live vaccine, we avoid it in pregnancy in individuals who are immunocompromised. So the sequencing, the data there for the pediatric vaccine is there. In adults, it is considered under the age of 26, and beyond 26, I'm not sure what the cap age is. It's probably close to 45 or so. Um, and recommendations for people who have not completed series for vaccine there. And being a live vaccine, again, contraindicated in immunocompromised or patients who are pregnant. So there's the adult guidelines for varicella vaccine and who are candidates for it at what ages. And finally, the zoster vaccine, herpes zoster vaccine. Herpes zoster is really the reactivation of varicella zoster. So folks who have had adequate varicella vaccination, since the vaccine was available as a vaccine in the 70s, 80s, folks who didn't get that, though, who are older than 50 years of age, they're at risk because they've had varicella in their history, exposure to it. Then all of those folks are candidates for herpes zoster. And you'll learn in derm that herpes zoster infection is a DNA virus with really quite punishingly painful vesicles, post-neuropathic pain that happens after the infection somewhat clears. The pain will persist. It results in an activation of an earlier varicella infection. Risk factors are older individuals and individuals who are immunocompromised. It presents typically as an eruption, often involving the trunk or the face, and we'll talk more about that in derm. Complications are this neuralgia and eye involvement that can be quite traumatic and concerning. So the epidemiology is person-to-person transmission, direct contact with the vesicles, but also keep in mind that we're, over the age of 50, people are reservoirs for that varicella already. Lots of cases in the U.S. Lifetime risk is about 30% for people over the age of 50 if you don't get vaccinated. The vaccine is highly effective. In the range of 95% or so. And it is not a pediatric vaccine, not pediatric. In adults, it's over the age of 50 or under the age of 50 if you happen to be immunocompromised and haven't had varicella vaccination. Again, varicella zoster, there's no real contraindications, although most patients, the data in pregnancy is not really there. So it really wasn't studied in women of childbearing age. And then there's the specifics. Okay, so you have gone through the vaccines.